Welcome to this module on critical appraisal of randomised controlled trials, which we'll refer to as RCTs. In this module, we'll demonstrate the key features of RCTs and the process for rapidly critically appraising them using the Rambo critical appraisal tool. In a randomised trial, a number of similar people are assigned in a random way to two or more study groups. One study group receives the intervention being tested. This may be a drug or non-drug intervention, such as a behavioural program or policy. The other group receives a control comparison. This might be a placebo, the current standard treatment, or no intervention at all. The participants in both groups are followed up to see if there are any differences between them in study outcomes. The information from the comparison group allows us to see whether the intervention we are testing is more or less effective than a control condition. Randomised trials, by definition, randomly assign study participants to either the intervention or control group. Random assignment means the allocation or placement of study participants into the study groups is based on chance alone. Placement is not decided by the researcher or the participant. Randomisation, when done well, creates groups that are alike in all aspects apart from the treatment being tested, and ensures the comparison between the intervention and control is fair. Imagine if, rather than randomising participants to groups, they were placed into study groups based on their age. If the group receiving the intervention treatment were all older and those receiving the control treatment were all younger, we couldn't tell whether the way the treatment affects participants in either group is due to the treatment itself or due to the difference in age. Age in this instance is what we call a confounder, a factor that confuses or distorts the association between the treatment of interest and the outcome. Randomisation results in the even distribution of known and unknown characteristics or confounders across the study groups, so that any differences we observe in outcomes between groups at the end of the trial are likely to be due to the intervention being tested. There are many checklists available for appraising RCTs. Some tools help you do rapid appraisals and, as the name suggests, can be applied very quickly to a study. Common rapid appraisal tools for RCTs are the CAHPR checklist and the Rambo checklist from the University of Oxford. Both tools assess the same key components of study conduct where bias can be introduced, so which you choose is a matter of personal preference. Some appraisal tools are designed for very detailed assessment of risk of bias. ROB2 is an example. These tools are suitable for appraising trials included in a systematic review or when trials are being used to inform a practice guideline. We'll focus our attention in this module on rapid critical appraisal using the Rambo appraisal tool. Rambo stands for randomisation, attrition accounted for aside from, and measurement, where we look at blinding and the objectivity of outcome measures. For each item of the Rambo checklist, we answer yes, no, or unclear if there's insufficient information. When doing a rapid appraisal, it's not necessary to read the research paper from start to finish. The information you'll need to apply Rambo is usually found in the methods and results section of the study. The rest of the study report can be safely skipped for most rapid critical appraisals. By using Rambo to focus our attention on the key aspects of trial conduct where bias can be introduced, and by doing focused reading of the research paper, we can quickly assess threats to the validity of the trial. The first item of Rambo is randomisation. When appraising an RCT, it's not enough for a trial to say it's randomised or used random allocation. It's important to look closer at how the randomisation was done, and there are two things to consider here. Firstly, whether participants were allocated to study groups randomly, in other words, by chance alone, and secondly, whether the allocation order, or the order in which participants would be placed into study groups, was concealed or hidden. You'll find this information in the methods section of the paper, and we'll discuss both issues further now. The first thing to look at is how the allocation sequence, or the order in which participants go into the study groups, was generated. Ideally, a random numbers table or computerized program that generates random sequence is used. These methods create a random sequence that results in participants being assigned to the study groups on the basis of chance alone. Other manual methods, such as rolling dice or drawing a number out of a hat, theoretically lead to random allocation sequences, but are less ideal because they can become non-random. They can be manipulated and cannot be checked. Methods where the allocation to groups is not considered random include allocation based on hospital number, alternation of participants, or assignment to group by date of birth. We would have most confidence in the sequence generation approach when the investigators mention that a table of random numbers or computer random number generator was used, because these options represent reliable, reproducible approaches to randomly allocating participants to study groups. The second component of effective randomization involves concealing or hiding the order in which participants will be assigned to study groups from those enrolling participants into the study or allocating them to study groups until the moment they are allocated. This is called allocation concealment and is necessary because the benefits of randomization can be undone if the order in which participants are assigned to the study groups is interfered with in any way. When allocation is not concealed and study personnel know to which study group the next eligible participant will be allocated, it is possible for personnel to manipulate or interfere with whether a participant is enrolled in the trial or to which group the participant is allocated. For example, a researcher with a strong belief in the benefits of a new intervention they're testing could, in theory, selectively exclude potential study participants from receiving the intervention if they feel that participant is likely to have a worse outcome. Concealment of allocation is an important safeguard against bias in randomized trials. Lack of allocation concealment may result in the creation of study groups that are not similar, and as such we cannot know whether any difference in outcomes between the study groups at the end of the trial are due to these differences or due to the intervention itself. The ideal method of ensuring allocation concealment is via a process known as central randomization. In central randomization, the randomization order is held securely in a location remote to where participant recruitment occurs. Once a researcher identifies an eligible trial participant, the researcher contacts the central center by phone or computer and provides the participant's enrollment details. Only once enrolled by the central center is the intervention the participant will receive revealed to the researcher. A less ideal but still acceptable method is the use of sequentially numbered opaque and sealed envelopes. Again, only once a participant is enrolled is the next numbered envelope opened and the intervention the participant will receive revealed. It is important to understand that allocation concealment is not the same as blinding in a trial. Allocation concealment prevents bias up to the point where participants are allocated to study groups, whereas blinding concentrates on preventing bias after participants have been assigned to study groups. Allocation concealment can always be implemented in a randomized trial. Blinding cannot. When a study reports use of either method and an appropriate method of generating the randomization sequence, such as a random number table or computer random number generator, we can feel confident that bias up to the point of allocating participants to study groups is minimized. In the next step of our appraisal, we check how similar study groups are for important demographic, clinical, and disease characteristics. Although proper randomization methods produce study groups that are comparable in terms of these features, differences can occur by chance, so it's important to check study group similarity at the start of the trial. This information is usually found in the results section of the paper in a table of baseline characteristics such as this. Differences between the groups do not need to have been statistically tested, and in fact providing p-values for differences between the groups can be misleading. What is needed here is to eyeball the data in the table to see if there are any meaningful differences, with meaningful differences referring to differences in characteristics that could influence or confound the results of the trial. Ideally, the table will provide information about socio-demographic characteristics, measures of the severity of the condition of the participants in both study groups, and the key outcome of the study at baseline. When groups are similar at baseline, we can be more confident that observed differences in outcomes between the study groups at the end of the trial are related to the intervention rather than to confounding factors. If it's clear that the study groups are similar at the start of the trial, you would answer yes to this checklist item. If important features have not been compared, you would answer unclear. If there are important differences between the study groups, you would answer no to this checklist question. For the A in Rambo, we need to consider three things. Firstly, were participants in the trial accounted for? This information can usually be found in the results section of the paper. What we want to understand here is the flow of participants through the trial. We want to know how many participants randomised did not actually receive or start the intervention, how many stopped taking the intervention, and how many did not attend follow-up where study outcomes were measured. We need to look carefully at whether the number of participants who dropped out and were lost to follow-up were different between the study groups. When there's differential dropout between groups, knowing the reasons is important. It may be the intervention is not acceptable or difficult to implement. Generally, if more than 15 to 20% of participants are lost from a study overall, or when there's a difference in the proportion dropping out between the study groups, we need to consider the results with caution, as people who complete the trial often differ from those who do not. This may lead to bias, but not always. It does depend on the reason for dropout and the way the data are analysed, which we'll discuss shortly. When a study provides a flowchart like this and clearly reports loss to follow-up and reasons for that loss to follow-up, you would answer yes to this checklist question. The second part of A in Rambo is analysed. Here we consider whether all the participants who were randomised were included in the analysis and were analysed in the group to which they were randomised. When this is done, it's called an intention to treat or ITT analysis. ITT analysis maintains and preserves the benefit of randomisation. By including in the analysis everyone who was randomised, even if they drop out or move to another study group, ITT tells us how well the intervention would work in most people at the level of adherence observed in the trial. ITT analysis is the ideal approach to analysing data from an RCT. The first requirement of ITT is that participants are analysed in the group to which they're randomised. Sometimes what happens in a trial is that study participants will change study groups. For example, in this trial comparing surgery and physiotherapy, some who were randomised to surgery did not end up undergoing surgery and had physiotherapy instead, and some who were randomised to physiotherapy had surgery instead. Even when this happens, it is critical that the participants who were randomised to therapy are analysed in that group and that participants randomised to surgery are analysed in that group. The second requirement of ITT is that all participants that are randomised are analysed, but we've just discussed the problem of dropout or loss to follow-up in trials. When participants are lost from a trial, we may not have outcome data for that participant. Strictly speaking, in this instance, ITT is not possible. Not all randomised participants can be included in the analysis because we don't have any data for them. However, researchers can manage this problem by creating and imputing plausible outcome data where it is missing. Some methods of imputing data are better than others, with what is called multiple imputation the gold standard approach. However, if loss to follow-up from a trial is high overall, i.e. greater than 15 or 20%, or there's a large difference in loss to follow-up between the groups, imputing data can still lead to biased results. When imputation is used, the researchers should check the effect of using imputed data on the results of the trial. They may do this by comparing the results of the trial when imputed data is used and the results when only the participants with outcome data are analysed in what's called a sensitivity analysis. If the results do not differ, either approach to analysis is acceptable. To summarise, if all or almost all participants who are randomised are followed up and have outcome data that's analysed according to the study group to which they were randomised, we would answer yes to this Rambo item. If there's been some loss to follow-up but multiple imputation has been used and the effect of using imputed data examined and use of this data found not to change the trial results, we could also answer yes. If participants are not analysed in the groups to which they are randomised, or there is a large loss to follow-up with missing outcome data for many participants, and only the participants remaining in the trial are analysed, we would answer no to this item and consider bias from inappropriate analysis likely. The final A of Rambo asks whether the study groups were treated the same, aside from the different study interventions received. This is often not well reported, but you may find this in the methods or the results section. Ideally, we would like to see that both study groups received the same allowed additional treatments or tests, or had similar contact with study personnel. We do not want to see additional treatments or care purposely added to just one of the study groups. If the study groups are not treated equally, we may be less sure that any differences in outcomes between the groups at the end of the trial are due to the treatment being studied. If a trial indicates additional treatments or care were purposely added to just one of the study groups, we would answer no to this question on the checklist. If there's no information or insufficient information to judge, we would answer unclear. The last issue to consider when appraising an RCT is the trial outcomes and blinding. Blinding is when people involved in the trial do not know whether the study participant is receiving the intervention or the control. People who can be blind in a trial include the participant themselves, any people caring for the participant, administering the intervention or collecting or assessing study outcomes. Blinding helps reduce bias by ensuring that participants in the study groups are treated exactly the same in all respects during the trial. We can then be more confident that observed differences in outcomes between the study groups at the end of the trial are related to the intervention rather than to differences in the care received. You'll find information about trial outcomes and blinding in the methods section. The importance of blinding depends on how subjective or objective the study outcomes are. By study outcomes, we're talking about the study endpoints or events that are measured to determine the impact of the intervention and control. Some outcomes are objective, such as death, cholesterol or blood sugar level, and some are clearly subjective. Pain and quality of life are examples. But often outcomes fall somewhere on a continuum between subjective and objective. Heart attack is an example of this, as it may be objectively defined, but reaching that objective definition requires some clinical judgment. It might be helpful to think of it this way. A subjective outcome is usually something that involves a high level of judgment or input from an assessor, or is a patient-reported outcome, or something only the participant can know. Where an outcome is clearly subjective, or some subjectivity is involved, blinding is critical. As you're probably already thinking, blinding participants, clinicians and trial investigators as to who's receiving an intervention or control is not always possible. This would be the case in a trial comparing a counselling intervention with an information pamphlet, for example. Clearly the participants and the people providing the counselling would know who's receiving it. Where participants are not blinded, knowledge of group assignment may affect their behaviour in the trial and their responses to subjective outcome measures. For example, a participant who's aware they're not receiving counselling may be less likely to comply with the trial protocol or seek more treatment outside of the trial. Conversely, participants receiving counselling may be very hopeful about its effects or may not want to let the researcher down. For this reason, they may exaggerate the benefits and minimise the side effects. When a study outcome is subjective, blinding is crucial for preventing bias. When a study participant is reporting the study outcome and they are not blind to the intervention they are receiving, the results should be interpreted with caution. You can find information on whether blinding has occurred, who is blinded, and the type of outcomes and how they were measured in the methods section of the paper. If the study outcome is clearly objective, you would rate yes for this checklist item. If it was not objective, but the people assessing the outcome were blind to whether the participant had received the intervention or control, you may also rate this item as yes. So we've reached the end of the Rambo checklist. The questions in the checklist draws our attention to the key aspects of trial conduct that can lead to the introduction of bias. By using the checklist together with focused reading of the methods and results section of a study report, we can quickly determine the validity and trustworthiness of the study. If you answered yes to all the Rambo checklist items, you can be confident that the study's been conducted in such a way that the risk of bias is minimised. If you answered no or unclear to all or most of the items, You may consider looking at a different study if there are others available that address your question. Often, however, you will have answered no or unclear to some of the Rambo items. When this is the case, it's helpful to consider if any of these are fatal flaws. That's significant error in the research design that invalidates the findings to a point where you don't think the trial results are credible or usable. It may also be helpful to think how the bias may be impacting the results of the trial. Is it likely to exaggerate or underestimate the true effect of the intervention? This is often not easy to determine, particularly when you're new to critical appraisal. But you will become better with practice and further reading of some of the resources mentioned later in this module. Remember, the point of critical appraisal is to determine how much trust you can place in the results of the study you're reading. Your interpretation of the results of that study should always be informed and coloured by your assessment of the risk of bias in the trial. We hope you've enjoyed this video. If you have any comments or suggestions for improvement, please use the contact information provided here. This video was developed by the Institute for Evidence-Based Healthcare at Bond University with support from the Council for Allied Health Professions Research, Northern Ireland Hub.